I have been an ICU nurse for 18 years. I actually still work as a critical care nurse. So the way that I got started doing research and administrative burden, probably around 5 years ago, and at that time, I didn't really even have a word for it. It's like calling it hassles, bureaucracy. And so the first question was sort of establishing, is there really a problem here that needs to be studied and needs to be solved? And I had the opportunity to collaborate with Austin Fracht, who is an economist with the VA, with Boston University, with Harvard T.H. Chan School of Public Health, and with the Urban Institute, because Austin and I connected over our shared frustration with this red tape. And he had a colleague at the Urban Institute who said, we run this national survey. Would you like to put a question module on there? And so that's what we did. So the first study that I did in this line of work was a national survey modeled on questions that have been fielded for decades about delayed and foregone care due to financial costs. I took the same question structure, and instead of asking about financial barriers, I asked about administrative barriers. And that was a survey of the general public, adults 18 to 64, who were continuously insured in the past year. And so they may or may not have had health issues. And that was a terrific place to start because, you get the sense of like, oh, what's going on in the general public? And at that time, we didn't know, is it going to be a 1%? Or like we had no idea like the magnitude of the problem, if any. And maybe one of the things we would learn from that is not a big deal at all. But what we did learn was that about 1 in 4 people reported delayed or foregone care due to an administrative barrier. So that's like scheduling appointments, dealing with a prior authorization, dealing with a billing issue, finding out which of your providers are in network, what services are covered. But something that really is the first thing anyone's telling me, especially in this past year, is the phone system. And patients have all kinds of problems. But I guess the summary takeaway is that getting a person on the phone in the healthcare system is very difficult. You get put into a phone tree. You get passed around to different, menus, and then different mailboxes where you leave a message and wait to be called back. And this comes up a lot for my cancer patients. They have experience now managing cancer, and they actually have pretty good insight into when am I dealing with a problem and what needs to be done. Like, I'm getting this side effect and I know what needs to be done for it. For example, like I have thrush or I'm getting a UTI. And the frustration that patients express is that they know what's happening, they know what needs to be done. And this is especially an issue outside of 9 to 5, but there's no easy way just to call up and say, hey, I've got thrush, can you order me some magic mouthwash? And I will get it from the pharmacy. And because it's difficult to reach a person quickly, or you leave a message, you don't know if you're going to get called back, it may not get picked up until after the weekend or till the next day, what ends up happening is that people end up going to urgent care or to the ER or using healthcare that they know was avoidable, but they didn't have another way to communicate with a clinician about what their need was. And I highlight that example because the phones are just the number one thing I'm hearing about right now. And it sounds so trivial, but I think that it's pretty important, not only for the clinical outcomes and patterns of care that we're observing on the delivery system side, but just also, again, I have to come back to this point about like patient stress. And we're talking about how we want the healthcare system to be more equitable and to, build trust with the community that we care for and our patients. And then the first thing we do is like give them a phone number that's not that helpful. So like I said, the thing that's always top of mind is we're identifying these problems, but I don't want to identify a problem without also having some sense of what could be a solution. And so there's a lot, I think, of different things to do, which is exciting. But if I was going to say today, what's one place that we can get started? It's going to be with administrative staffing. And I'm very, very familiar, as I think we all are, with the clinical staffing challenges in healthcare right now and the stress that the whole workforce is under. But I think that a fast way to sort of bring more hands on deck is to try and improve some of these immediate frontline administrative issues. So, one, the extent to which you can have a human being answering the phone, really important. The other thing is, I have a parallel line of work as I'm surveying patients. I'm also surveying practices, and practices are thrilled to be asked about this because they're very stressed, and they're sharing with me like it's hard to be like the first thing that's difficult to justify is like another person to answer the phones, another person to like scan PDFs into Epic. If you have 50,000 pieces of paper flying through your office, like you need hands to do that. And so I think the key takeaway that I want to share is that a lot of this administrative work, we sort of classify administrative work as waste. It's not all waste. A lot of this work, it improves the efficiency of the system, improves the experience for patients, and improves the experience for clinicians. So I think it's well worth the investment, and it's something that we can do quickly.